Imagine a patient's brain swelling inside their skull. I mean, their labs are crashing, their mental status is deteriorating by the minute, and you reach for the chart to see what the attending physician wants you to do.
Right, but there is no attending.
Exactly. The room is totally empty. It's just you, the patient, and a decision that has to be made in like the next 60 seconds.
Which is terrifying, honestly. But that is the moment every medical trainee prepares for. Actually facing it, though, that is a whole different reality.
It really is. And welcome everyone to our deep dive into the source material. Today we're unpacking the NMS review for USMLE Step 3 by Dr. Mitchell H. Rosner.
Yeah, and whether you're a medical student, a resident deep in the trenches, or, just a self-taught learner who's fascinated by the intense reality of clinical medicine, this deep dive is designed specifically for you.
Right, because we are going to strip away all that unnecessary jargon. We're looking at how a physician prepares to manage a patient safely without anyone looking over their shoulder. So we're talking test-taking psychology, high-stakes emergency vignettes, and the underlying mechanisms of why diseases actually behave the way they do.
Because this specific material, it represents the ultimate assessment of a physician's ability to assume independent responsibility. I mean, you transition from being a student who just suggests a plan to the physician whose license and whose patient's life is literally on the line.
Yeah, the stakes are incredibly high.
Yeah.
And the focus is heavy on ambulatory settings, right? But it aggressively spans urgent care, continuous care, initial workups. The author doesn't even treat this like a standard medical exam.
No, not at all. The text explicitly compares preparing for this to going into battle.
Battle, which means you can't just, wake up, drink a bunch of coffee, and wing it.
Definitely not. The text outlines a realistic 3-month strategic plan.
But what really stood out to me wasn't the scheduling. It was the psychological trap the author warns about. The text uses this great analogy about the golf range. Like when you go to the driving range, do you take out the club you actually need the most work on, or do you just pull out the driver and hit the long ball over and over?
We hit the driver every time.
Exactly.
It is human nature to want to reinforce what we're already good at. Answering questions correctly, it provides a dopamine hit. It makes us feel competent.
Right. It feels good to be right.
Yeah, but the text emphasizes that spending your most valuable study time on your strongest subjects is a fatal flaw in your battle plan.
Yeah.
Like if your weakness is biostatistics or pediatric infectious disease, that is exactly where you need to force yourself to live for the next few weeks.
You have to actively confront the subjects that make you uncomfortable.
Exactly.
Which kind of makes me think of the actual mechanics of working through these clinical cases. The source material points out that you might only have about 1 minute per question.
Yeah, time is a massive factor.
And these aren't simple flashcards, right? They're massive paragraph-long vignettes filled with what the author calls red herrings. So if I'm staring at a wall of text about a patient's entire medical history, their social habits, a dozen lab values, how am I supposed to process all that and spot the trap in 60 seconds?
Well, you don't read it like a novel. The most effective strategy the author advocates is to look at the actual question at the end of the passage first.
Wait, read the last sentence first.
Yeah, before you read a single word of the patient's history.
Doesn't that mean I'm missing the entire clinical context, though?
Not at all. It changes your whole cognitive framework. So a vignette might give you a painstakingly long description of a patient's chest pain, right?
Yeah.
It draws you completely into thinking about a heart attack, gives you an ECG reading, and then the actual question at the very end is simply, what is the most common side effect of the medication used to treat this patient's underlying gastric reflux?
Oh, wow. So all the chest pain stuff was just noise.
Exactly. If you know they're asking about medication side effects, you aren't passively absorbing the chest pain narrative. You're actively scanning the data for the reflux medication. It is vastly more efficient.
It's like knowing you're looking for Waldo before you even open the picture book.
That's a perfect way to put it. You just scan for the red and white stripes instead of looking at every single person in the crowd.
Makes so much sense. And speaking of the marathon of studying, the book talks a lot about peaking at the right time.
Yeah, pacing is everything. You want your cognitive performance to peak on the exact day you are tested, not the week before.
Right.
If you're pushing so hard that your practice scores start dropping a few days out because of mental fatigue, you have fundamentally compromised your strategy.
So you have to rest.
Taking a full day off to let your brain consolidate information is actually a strategic imperative.
Okay, let's actually put this strategy to the test. Let's look at one of the high-stakes urgent care scenarios from the text. I really want to look at the pediatric emergency case.
Okay, let's lay out the clinical data.
All right, so we have an 11-year-old girl brought to the emergency department. Over the past 2 days, she's been experiencing polyuria peeing, constantly polydipsia, which is extreme thirst, nausea, vomiting, and diffuse abdominal pain.
Classic symptoms.
Right. And on physical exam, she's lethargic. Her skin turgor is poor, meaning like if you pinch the skin on the back of her hand, it stays tented up instead of snapping back. So she is severely dehydrated.
And we need to look at her labs immediately.
They are incredibly alarming. Her blood glucose is 534 milligrams per deciliter. Normal fasting glucose is under 100.
Right.
And her arterial blood gas shows a pH of 7.13 with a PCO2 of 20. So her blood is profoundly acidic.
Yeah, this is the textbook presentation of diabetic ketoacidosis, or DKA. Because she lacks insulin, her cells are essentially starving in a sea of plenty. The glucose is in the blood, but it can't get into the cells.
So her body panics.
Exactly. It panics and starts breaking down fats for energy, which produces highly acidic byproducts called ketones. That explains the dangerous pH of 7.13.
And the PCO2 being down to 20, normal's around 40, right? So she's hyperventilating to blow off carbon dioxide.
Precisely. Carbon dioxide acts as an acid in the blood. Her lungs are desperately trying to compensate for the metabolic acid by blowing off respiratory acid. It's a classic mechanism called Kussmaul breathing.
Those deep, rapid respirations. Okay, so the diagnosis is clear. We start an IV insulin drip and aggressive fluid resuscitation. But the text focuses heavily on the treatment complications.
It does.
It highlights that the most likely electrolyte disturbance to occur while you're fixing her is hypokalemia, so a dangerous drop in potassium. But why? Why does saving her with insulin cause the potassium to crash?
Well, this is where understanding cellular mechanics saves lives. Insulin is known for pulling glucose into cells, but it also heavily stimulates the sodium-potassium pump on the cell membrane. It actively drives potassium from the blood into the cells.
Okay.
And in a state of DKA, this patient has been urinating constantly, literally flushing her body's total potassium reserves down the drain.
Wait, but if she's been peeing it all out, why wouldn't her initial blood test show low potassium before we even gave the insulin?
Oh, because the profound acidity of her blood tricks the initial lab draw. All those hydrogen ions, the acid, they rush into her cells, and to maintain electrical balance, potassium is shoved out of the cells into the blood.
Ah, I see.
So her blood level looks normal or even high, but her overall body is completely depleted.
Wow.
The moment you give insulin and fix the acidity, all that potassium rushes back into the empty cells. The blood level just plummets.
Yeah.
If you aren't preemptively giving her IV potassium alongside the insulin, she could go into a fatal cardiac arrhythmia.
You fix the acid, but you accidentally stop her heart. That is absolutely terrifying.
A very fine line to walk.
And the text notes something else counterintuitive. To monitor if she's actually getting better, the best laboratory parameter isn't her dropping blood sugar, it's her anion gap.
Right, because the anion gap is a calculated number that essentially measures the hidden, unmeasured acids in the blood, in this case, the ketones. You can force a patient's blood sugar down to normal with enough insulin, but if their body is still actively manufacturing acidic ketones, they are still in a life-threatening crisis. When the anion gap closes, meaning it returns to a normal range, it proves the biochemical machinery has actually stopped producing the acid.
That makes total sense. But we aren't out of the woods in this vignette yet. 3 hours into her treatment, she starts complaining of severe muscle pain, profound weakness, and shortness of breath.
Yeah, we're looking at a secondary complication of DKA treatment now, hypophosphatemia or low blood phosphate.
Let me guess, the insulin pushes phosphate into the cells too.
It does. But the mechanism of why she feels weak is the crucial part here. Phosphate is the P in ATP adenosine triphosphate.
The energy currency of the cell.
Exactly. It's the fundamental energy currency of every cell in the human body. As phosphate levels drop critically low in the blood, her muscle cells literally cannot synthesize enough ATP to generate a contraction.
So the weakness is profound.
Yeah, and the shortness of breath occurs because her diaphragm, which is a massive muscle, is losing the energy to contract.
Unbelievable. Okay, so we managed the phosphate, but 9 hours in, we hit the absolute climax of the case. She's received 8.5 liters of fluid. Her potassium and phosphate are stable. Her anion gap has decreased from a dangerous 29 down to a beautiful 15.
Labs look great.
The labs look amazing. But suddenly, she complains of a severe diffuse headache. She becomes stuporous and unresponsive. If her labs are resolving, why is she crashing neurologically?
This is the most feared, uniquely pediatric complication of rapid DKA treatment. It's cerebral edema, or swelling of the brain.
Oh no.
See, when a patient has been walking around with blood sugar in the 500s, their blood is highly concentrated.
Wow.
To protect themselves from shrinking, the brain cells generate special molecules called idiogenic osmoles to pull water in and maintain their shape.
Okay, so they adapt.
Right. But when you rapidly flood the patient's bloodstream with IV fluids and drop the sugar, the blood suddenly becomes much more dilute than the inside of the brain cells.
And water always follows the higher concentration, so all that water rushes straight into the brain tissue.
Yes. The brain swells, but it is trapped inside a rigid, unforgiving skull. The intracranial pressure skyrockets, causing the severe headache and stupor as the brainstem is compressed.
Okay, so if my patient's brain is swelling and she's becoming stuporous, my immediate instinct is to rush her to the CT scanner to see exactly how bad the swelling is before I do anything drastic.
And if you do that, the patient will likely die in the scanner.
Wait, really?
The text is incredibly explicit here. Time is tissue. You do not wait for imaging. The immediate life-saving intervention is an IV push of mannitol.
Mannitol over a CT scan. Okay, how does mannitol stop the swelling?
Mannitol is an osmotic diuretic. It's a large, complex sugar molecule that cannot cross the blood-brain barrier.
So it stays in the blood vessels.
Exactly. It stays inside the blood vessels and radically increases the concentration of the blood. It acts like a powerful chemical sponge, literally pulling the excess water out of the swollen brain tissue back into the bloodstream where it travels to the kidneys and is peed out.
That is wild.
You have to recognize the clinical pattern of a headache and stupor in a DKA child and act immediately.
That reliance on immediate pattern recognition, rather than waiting for imaging or perfect information, that's a perfect transition because that exact same skill is the entire foundation of toxicology.
Toxicology is a brutal test of sequential knowledge. You have to know the specific poison, the clinical presentation, the exact mechanism of damage, and the precise antidote.
Let's look at the first toxicology case from the text. We have a 47-year-old man with a history of alcohol abuse who attempts suicide by swallowing a massive bottle of acetaminophen, just basic over-the-counter Tylenol. He arrives at the ER, and his family says he took the pills anywhere from 4 to 10 hours ago.
Acetaminophen is deceptive because it seems so safe. But in an overdose, it overwhelms the liver's normal, safe detoxification pathways.
Right.
The liver is forced to shunt the drug down a secondary metabolic pathway that produces a highly toxic tissue-destroying metabolite called NAPQI. The immediate intervention is the administration of N-acetylcysteine, or NAC.
Okay, so how does NAC neutralize it?
Normally, your liver uses a natural compound called glutathione to bind and neutralize that toxic NAPQI. But in a massive overdose, the glutathione stores are completely depleted.
Got it.
NAC works by stepping in and rapidly replenishing the liver's glutathione, essentially reloading the liver's natural defense system before the cells undergo necrosis.
That makes total sense. But here's the part of the text that absolutely stopped me in my tracks.
Right.
It asks what agent might actually be protective against liver toxicity in this specific scenario. And the answer the book gives is cimetidine, which is an over-the-counter heartburn medication. How on earth is an antacid protecting this man's liver from a Tylenol overdose?
It's crazy, right? The answer lies deep in the pharmacology. Cimetidine is primarily an H2 receptor antagonist used to lower stomach acid. However, it has a very prominent off-target side effect. It acts as a broad inhibitor of the cytochrome P450 enzyme system in the liver.
Wait, meaning it shuts down the liver enzymes?
Specifically, it shuts down the exact P450 enzymes that are responsible for converting the raw acetaminophen into that deadly NAPQI metabolite.
Oh, wow.
By accidentally jamming the gears of that specific enzyme system, the cimetidine prevents the poison from being formed in the first place. It's a brilliant piece of medical mechanism that tests if you truly understand the biochemical pathways.
You really have to know the how, not just the what.
Exactly.
Now, toxins can be acute, like an overdose, but they can also be insidious. Let's look at the pediatric environmental exposure case. We have a 6-year-old boy who is previously healthy but presents with vague symptoms, unexplained nausea, vomiting, and irritability. And the key history is that he's been playing at a friend's older house undergoing renovations.
Right. The clinical presentation of lead poisoning in children is notoriously vague. It often mimics a simple viral stomach bug. But the source material highlights a hallmark finding you absolutely must recognize on the peripheral blood smear: basophilic stippling of the red blood cells.
Okay, I see the term basophilic stippling all the time, But what is actually happening inside the red blood cell to make it look like that?
Well, lead is incredibly toxic to the enzymes responsible for cellular maintenance. Specifically, it inhibits the enzymes necessary to break down ribosomal RNA as a red blood cell matures.
Okay, so RNA is supposed to be cleared out.
Normally, a mature red blood cell clears out all its RNA, but in the presence of lead, that degradation is blocked. The leftover RNA clumps together.
Oh, I see.
So when the pathologist applies a basic stain which binds to the acidic RNA, those clumps show up under the microscope as scattered tiny blue dots throughout the cell. That is basophilic stippling.
Blue dots of undegraded RNA. It's fascinating how a heavy metal from paint fundamentally disrupts RNA at the molecular level. I mean, toxins attack directly, but sometimes the enemy is something that has been smoldering in the background for months. Let's look at how Step 3 tests opportunistic infections in vulnerable patients.
Yeah, the challenge here is distinguishing between life-threatening brain infections when a patient's immune system is severely compromised, like in advanced HIV or AIDS.
So the vignette introduces a 22-year-old man with a history of pneumocystis carinii pneumonia, which tells us his CD4 T cell count is incredibly low. He presents with a subacute history, meaning it's been slowly building over a week or two of severe headache, nausea, vomiting, blurry vision, and papilledema. Papilledema being the visible swelling of the optic disc when you look into his eye, which tells us the pressure inside his skull is dangerously high.
The differential diagnosis for brain lesions in an AIDS patient is broad, but on this exam, you are often forced to distinguish between two major culprits based entirely on the tempo of the symptoms: cryptococcal meningitis and toxoplasmosis.
Okay, well, if he has high pressure in his skull and a severe headache, I'd assume it's toxoplasmosis. Doesn't that cause massive abscesses in the brain?
It does, and that is exactly why toxoplasmosis is the wrong answer here. Because toxoplasmosis forms physical mass lesions inside the brain tissue itself, the presentation is typically acute and involves highly focal neurologic deficits like, say, sudden weakness in one arm and violent seizures.
Oh.
Cryptococcus, however, is a yeast-like fungus that primarily infects the meninges, the delicate fluid-filled lining surrounding the brain.
So it's not growing a localized tumor, it's more like it's clogging the plumbing.
That is the perfect analogy. The fungal elements physically clog the arachnoid villi, which are the structures responsible for draining cerebrospinal fluid. The fluid keeps being produced, but it can't drain.
So the pressure just builds up.
Exactly. It builds up globally and slowly. That leads to the subacute course of a generalized headache, nausea, and the papilledema without the distinct focal seizures you'd see with a mass.
And what's the definitive treatment protocol for this fungal clog? The initial induction therapy requires a heavy-hitting systemic antifungal called amphotericin B.
I remember reading about amphotericin B. It's notoriously harsh on the kidneys, right? Why do we use something so toxic?
Because of how it attacks. Amphotericin B binds directly to ergosterol, a unique component of the fungal cell membrane. It literally rips physical pores into the membrane, causing the cellular contents to leak out, rapidly killing the fungus.
Wow, just tearing it apart.
Yeah. And once the acute crisis is controlled and the fluid is draining again, the patient is transitioned to a much safer oral maintenance dose of fluconazole.
Got it. Infections don't just cause direct damage, though. Sometimes they confuse the body's own defense systems. The text throws in a classic neurological presentation right after this: Guillain-Barré syndrome.
Yeah, this is a prime example of molecular mimicry. Guillain-Barré is an autoimmune attack on the peripheral nervous system, almost always triggered by a recent gastrointestinal or respiratory infection.
The immune system generates antibodies to fight the bacteria, but those antibodies accidentally cross-react with the myelin sheath, the protective insulation wrapping around the patient's peripheral nerves.
And if the insulation is stripped away, the electrical signals from the brain can't reach the muscles smoothly.
Exactly. Without myelin, a process called saltatory conduction fails. The signal just degrades. Clinically, this presents as an ascending weakness. It starts with tingling and weakness in the feet and moves progressively up the legs.
Right.
And the absolute hallmark finding you must recognize is a complete loss of deep tendon reflexes.
So you tap their knee with the reflex hammer and nothing happens.
Nothing at all.
The nerve wire is so stripped that the signal can't even bounce back to the spinal cord. I mean, we've covered diabetic comas, heavy metal poisoning, and autoimmune nerve destruction. We're saving lives in the ER. But the author makes a point to remind us that the vast bulk of general medical care isn't ER drama. It's catching things early in an ambulatory clinic.
Which brings us to the math of medicine: biostatistics and preventative screening.
I know, the moment we say the word math, half of our listeners just tensed up or rolled their eyes. But the text insists that your gut instinct on interpreting lab numbers is probably going to get a patient hurt. We have to understand sensitivity, specificity, and positive predictive value.
Let's strip away the confusion. Sensitivity simply looks at the sick people. It asks, of all the patients who truly have the disease, what percentage did the test successfully flag as positive?
And specificity looks at the healthy people. Of all the people who do not have the disease, what percentage did the test accurately clear as negative?
Exactly, but neither of those numbers is what the patient sitting across from you actually cares about.
Right.
The patient only knows they got a positive test result. They want to know the positive predictive value, or PPV. They are asking, Doc, my test came back positive. What are the actual odds that I have the disease?
Okay, let's walk through the math example from the text very slowly. So we're using a new screening test on a group of people. The test identifies 80 true positives, people who tested positive and actually have the disease. But it also produces 20 false negatives, people who are told they were clear, but they actually do have the disease.
Right.
If I want to find the sensitivity, how do I set up that equation?
Well, remember the rule. Sensitivity only cares about the people who truly have the disease. So first, we find the total number of sick people. You have the 80 true positives plus the 20 false negatives who were missed. That means 100 people in total actually have the disease.
Okay, 100 sick people.
And the test correctly identified 80 of them. So 80 divided by 100 is 80%. The test is 80% sensitive.
Okay, that math isn't too painful. But the author stresses a critical clinical concept here. Sensitivity and specificity are hardwired into the chemical design of the test. They don't change. But positive predictive value is fluid.
Highly fluid.
It drastically changes based on the prevalence of the disease in the population you are testing.
This is perhaps the most important concept in preventative medicine. Imagine you use a highly sensitive test for a very rare cancer on a population of healthy 20-year-olds. Because the disease prevalence is incredibly low, almost every single positive result you get is going to be a false positive. Your positive predictive value plummets.
Which means you are sending dozens of healthy 20-year-olds for invasive, dangerous biopsies for literally no reason.
Correct. But if you take that exact same test with the exact same chemical sensitivity and use it in a high-risk oncology clinic where the prevalence of the disease is high, suddenly the majority of your positive results are true positives. The positive predictive value skyrockets.
Wow.
The mathematical rule is absolute. As disease prevalence increases in a population, the positive predictive value of the test increases.
That perfectly explains why we don't just run full-body MRI scans on perfectly healthy people. The math proves it causes more harm than good.
Biostatistics ultimately dictate ethical, effective clinical practice.
This brings us back to the core mission. Whether you're calculating the predictive value of a cancer screen, understanding how an antacid protects the liver, or pushing osmotic diuretics to shrink a child's brain, it all comes down to building a framework for independent reasoning. And as promised for our medical learners, let's run a quick review exercise to see if we can connect the dots in real time.
Okay, here is the scenario. You're working unsupervised in an urgent care clinic. A 52-year-old patient with a long history of severe alcohol abuse comes in complaining of severe leg cramps, generalized weakness, and burning neuropathy in his feet.
Okay.
You draw routine labs. The pathologist calls you and notes an unexpected finding on the peripheral blood smear, basophilic stippling. Based on what we discussed today, what specific environmental exposure must you immediately ask this adult patient about, and what pediatric presentation does this mirror?
Okay, let me think this through. Severe leg cramps, alcohol history, but the key is the lab result. Basophilic stippling, we talked about that. The RNA failing to degrade in the red blood cells, clumping into those tiny blue dots. That was caused by a heavy metal enzyme block.
Right.
So I need to ask this adult about lead exposure. Maybe he's, distilling his own moonshine in old lead-soldered car radiators.
That's a very real possibility.
And the pediatric presentation, it mirrors. That would be the 6-year-old boy playing in the old house who came in with vague nausea and vomiting.
Spot on. The patient's age and the source of the exposure changed entirely, but the underlying cellular pathophysiology and the pattern you had to recognize remained exactly the same.
I love how the mechanisms tie everything together like that.
They really do. And I want to leave you with one final thought as you prepare for independent practice. The source material notes that the USMLE Step 3 is actively transitioning. It's evolving beyond purely testing scientific mechanisms to heavily testing general principles, medical ethics, and jurisprudence.
That's a big shift.
It is. As you prepare to walk into that exam, and more importantly, into your own clinic, ask yourself, how will your purely scientific medical decisions hold up when viewed through the lens of modern medical ethics and strict legal scrutiny? Because out there, without the training wheels, you aren't just a scientist treating a disease. You are a physician legally responsible for a human being.
That is a phenomenal reality check to end on. You need the underlying science, but you also definitely need the wisdom to apply it. Thank you all for joining us on this deep dive into the source material. Keep questioning the mechanisms, keep connecting the dots, and we will see you next time.